Hello everyone, thank you for joining us today. My name is Dr. Eileen Pangan. I am a rheumatologist and Executive Medical Director at AbbVie. In my role, I focus on the development and execution of clinical trial programs that evaluate the safety and efficacy of new medicines that have been discovered by AbbVie researchers. Our goal is to enable patients to live a life not limited by their disease. So today, we're going to talk about remission in rheumatoid arthritis. And I am joined by Dr. Bukhari, consultant rheumatologist from the University Hospitals of Morecambe Bay, NHS in the UK, and by Claire Jacqueline, Deputy CEO of the National Rheumatoid Arthritis Society. Welcome.
Hello.
Hello.
So I'd like to start off by asking each of you to tell us who you are and what is your experience in rheumatology. Dr. Bukhari?
Hi, well, I'm from the northwest of England. I trained in rheumatology in Manchester in the northwest of England, after which I did a PhD in epidemiology, and after working as a research fellow for a while. Then I started my consultant job at the Royal Lancaster Infirmary in Morecambe Bay, and I've been there ever since. I've held a few national roles looking after patients, and part of it is being an advisor to the National Rheumatoid Arthritis Society. I do a bit of research, and my interests really are rheumatoid arthritis, patient outcome measures, and epidemiology.
Excellent, thank you very much. Claire, why don't you tell us about your work advocating for patients with the NRAS?
Well, first of all, I've been working with the National Rheumatoid Arthritis Society now for 12 years. So I've seen how things have changed over that period of time, and I've been very much involved in advocating for better access to treatments, better self-management techniques, better education for patients as well, which is very, very important, because one of our favourite sayings in NRAS is, you don't know what you don't know. And we're there to really help patients along that pathway, and it can be a very difficult pathway with living with rheumatoid arthritis.
Well, thank you. It looks like both of you have done a lot of work to really help our RA patients. I think one of the things we've learned is that RA can really have a significant impact on the lives of patients at different stages of the disease. And so, Claire, tell me more about what you've seen with the patients you work with. What do they experience as RA patients?
It's very different in different people. I mean, rheumatoid arthritis is it's more than a disease, it's a syndrome, and there are almost different subtypes within the condition. So for one person, it might be quite mild, it might be quite manageable, and they can live very full and active lives. And then for other people, right at the other end of the spectrum, it can infiltrate in every aspect of their life. And a way to sort of imagine, there isn't such a thing as an average rheumatoid arthritis patient, but imagine if you're a young mum in your 30s, you've got a baby, you've got a toddler, you've got a job, and you've got to get up maybe an hour and a half earlier than the rest of the family to get going in the morning stiffness, have to take lots of medications, then trying to cope with all that, and then trying to get a child into a car seat when your fingers are painful. So it's like everyday things that most of us would probably take for advantage of, just getting down the stairs without even thinking about it. That's what people have to live with. But some of the biggest impacts is on emotional health and working lives as well, and interacting with family.
I mean, you've clearly described a lot of significant impact that this disease might have, not just on the physical health, but mental health of the patients. And Dr. Bukhari, based on what Claire has described as the daily experience of the patients she works with, how does this influence your practice and your perspective on the work that you do in RA?
Well, it does influence it quite significantly. So in the day, we used to always worry a lot about tender joints and swollen joints, and erythrocyte sedimentation rate, and what the patient global is and what the disease scores are. But more recently, I've been to ask my patients, what is the arthritis stopping you from doing that you really enjoy? What is it that you would like to be able to do that you feel that's being stopped? And if you manage to get a good medium between that and getting the disease activity as you measure it down to where it is, and getting the patient to be able to do that extra hole of golf, or pick up their grandchild, or go and socialize and maybe go and dance without having to hurt the next day.
Yeah.
That can sometimes be more rewarding than than being told, well, my joints aren't sore, but I still don't feel well,
Yeah.
which is sometimes you hear a lot, in that patients will have no swollen joints, but will still have a significant amount of patient global, and you have to ask them, what does that mean to you?
Yes.
So I'd like to move on to remission, which is what I really want to talk about today. Remission is often a word associated with a disease like cancer, but what most people don't know is that chronic diseases like RA can also lead to remission if given the right treatment. So I think that's very important that as we take care of these patients, we find the right treatment for them, because the primary goal really ultimately is remission for these patients so that they can get on with their lives.
Yeah.
So Dr. Bukhari, tell me from a clinician's perspective, what is remission to you?
Well, remission can mean several things, but to me, the remission is complete control of disease, and the patient coming to tell me and saying, I don't feel I do have rheumatoid anymore. These drugs and this medication, what you have done has made me feel like a normal person again.
Yeah.
Now that is very rare to get.
Claire, what about you? What does remission mean for you and the patients you help with?
Well, I think remission is one of these words that, your average person, when they think about remission, often think that it's a cure. And then they find it difficult to think, well, I'm in remission, so why should I continue to take my medication? So I think we have to be very clear when communicating with patients that remission might be, treatment-induced remission, that they still need to keep taking their medications to keep the disease under control and keep it in remission. What does remission feel and look like for a patient? And it might be, it's more to do with quality of life, being able to feel normal, being able to be spontaneous again, and not have to think, if I'm going to a wedding next week, I'm really going to have to take it easy the day before and then plan nothing the day after. To take that sort of minutiae of detail that their disease is controlling them instead of the disease, them controlling the disease. I think that's what true remission will mean to people. But not everybody will be able to reach remission.
Well, thanks for sharing, Claire. I think in my line of work, it's very important for us to understand what the patient's unmet needs are, because that is what propels us every day. We need to understand how we can bring new treatments so that more patients can get optimal therapy. So how do you think the patients that you work with, how can they advocate for more optimal treatments for RA?
Well, I think there is that drive to finding the magic cure or the magic elixir of life in a way, but it is more than just finding the next good treatment. It is about the whole multidisciplinary team to supporting a patient to reach remission. But so optimum care is more than just the treatments, but it's very key is self-management and education of the patient to know what they can do for themselves, because they see their healthcare professionals maybe once or twice a year. The rest of the time they're managing on their own. So to advocate that they need investment in their patient education, and that's where I think the patient organisations can play a key role. Knowing education is the key thing. If patients are aware of what does rheumatology good care look like, what should I be accessing, what should be offered to me, and if they know that and we can provide that as patient organisations, they're far more informed to have that conversation than when they go in to see their consultant and say, not in a confrontational way, but actually be a partner in their healthcare and work with their team to get to the right remission, hopefully.
I mean, I think, Claire, you're absolutely right. The patient should be the best advocate for himself or herself. And I think clearly we've come a long way in the treatment of rheumatoid arthritis, and you've hit on the two things that I think are really important: awareness and education, because that's the only way they will know that they can expect more from their physician in terms of treatment. So, Dr. Bukhari, you've been working in rheumatoid arthritis for many years. Can you speak to some of the changes you've seen in the treatment of rheumatoid arthritis.
Oh yes, in the early 90s I was working in a specialist rheumatology hospital where we had 2 wards full of patients who were on strict bed rest. And that's how it was treated. You had strict bed rest and joint injections and maybe a few drugs. And then as time went on we started to use drugs, and we then developed more of the disease modifying drugs. And we then suddenly, in the late 90s towards the early noughties, we started to get quite a lot of new and newer molecules. And what's happened now, the accelerated rate at which we've now got agents for rheumatoid has been astonishing. And in fact, it's almost exponential from the point of view, and confusing for a lot of health professionals. And in fact, the one thing that I've noticed that we're doing a lot more is that everybody's looking to say, well, how do I know which drug I use for which patient, rather than saying, well, everybody gets the same progression of drug going up from one to the next to the next. So there's now a choice, there's a variety, there's quite a lot of science looking at biomarkers, predictors of response, and that's what everybody wants to know, which patient will respond to which drug, so you can actually put them on the right place. And that's how it's gone. So bed rest and lots of injections and not much happening. Patients' joints getting worse and worse. I mean,
many consultants says, that have been around for many years, said they used to be experts in wheelchairs, all the different makes.
Sure.
That is something we're not seeing anymore.
Right.
Thank heavens.
Right.
But yes, you're right. It's changed so much in such a reasonably short space of time, really.
Right.
And I mean, rheumatologists who have trained probably in the last 10 years versus who've trained more than 20 years ago will have really seen that their working life has gone.
Right.
Looking after patients on ward is not really something that people will do. We're working more in multidisciplinary teams. We've got extended scope within our teams with physiotherapists and nurses and pharmacists. And occupational therapists and podiatrists with most of the teams. We're recognizing the need that we actually need psychologists in our team nowadays, but we don't have that capacity in the UK. But there is, there's a team approach towards the patient, with the patient being at the center, which is the important thing nowadays. Back in the day, it was always about the fact that we were fighting a disease that we didn't have the tools to fight.
Correct.
We now have the tools, we just need to figure out how to use them.
Yes. Okay. Thank you. I mean, I think the emergence of therapies have really revolutionized the treatment of rheumatoid arthritis, as Dr. Bukhari has explained. And now having targeted therapies that have been developed specifically for rheumatoid arthritis. And I think that innovation is really driven by a better understanding of what the disease is and the many ways we can block the inflammatory process in RA. And at AbbVie, our research is really driven by our desire to continue advancing that science because we have to face the fact that we still need new therapies for rheumatoid arthritis. But I think the greatest impact that I've seen, I've been a rheumatologist now for nearly 20 years, is that we have now patients who can come to the clinic of Dr. Bukhari and be offered treatments that not only control the symptoms, but hopefully can also halt or potentially stop the joint destruction, which I think is very important in the long-term care of these patients.
So do you think that there's been a change in the way that the doctors look at approaching the unmet need as a researcher? Do you think that that's changed as well?
Right, because I think the bar has been raised. I think because now that we can do more, right, I think the treatment goals have gone from just take away my pain to what you've described as I really want to go into low disease activity or remission. And the patient's expectations have also changed, I think, right? Because in the past, you're right, they'll go to Dr. Bukhari's clinic and they'll see several wheelchairs, but now they expect to be able to do the type of things they used to do before their disease got diagnosed. So I think that's really important. Now, as a patient advocate, Claire, have you seen or heard patients talk about these improvements that they've seen in the way they're being cared for by their rheumatologist?
The number of patients now, I talk to hundreds of patients right across the UK that I see that are really responding to these advanced therapies. Right. But I think there's a lot as well that we need to learn from other disciplines about how these other autoimmune conditions actually work together. And I think that, you know, more collaborative working between oncology and dermatology and gastroenterology and rheumatology will really highlight that in the future. So we'll see a lot of developments, I think, coming in the near future, we hope.
Well, I think I would like to actually call it more personalised.
Yes,
rather
right,
than, yes.
yeah.
So you actually take the person and you actually look at their phenotype rather than saying, I want to target this, I want to target that.
Yeah.
That's not really how we would want to see it. But you'd want to take the person as a component of several bits of disease and then decide which part of the disease you'd want to deal with and then give the right drug that will actually deal with all of those elements. And I think that's where we will try and see where things are going to be going. Yeah. And patients, yes, they do sometimes demand quite a few things that we can't do. We can't make them 20 years younger, but we can give them, we can try and make their disease better.
Right.
And they put up with a huge amount of pain and discomfort because they think, well, this is as good as it gets.
Right.
And I think it comes back to that message of education. The more they realise that actually, you know, they are worth it. They do deserve more, and you know, to not settle for just as good as it gets, you know, to be a little bit more demanding.
Good.
I'm sure you're delighted to know that.
So can you enlighten us?
Yeah.
I mean, that's right, you must be aware of quite a lot of things. So what do you think that AbbVie will be looking at from the point of view of professionals and patient advocates? What are you going to offer us for what's on your menu of, or a smorgasbord of things for rheumatoid? What do you think you will be able to offer?
Right. So at AbbVie, we continue to work to advance the science in whatever field or disease we're working in. So for example, rheumatoid arthritis, I think we are still striving to better understand the disease, identifying new targets, and perhaps even discovering biomarkers, as you pointed out, that could help us identify which medicines should be for which patients. Because ultimately, we would like to be able to bring remission with the right medicine for the right patient. But really, we cannot do this work alone. I mean, I think that's why we are really encouraged to have you here today, because I think partnerships with rheumatologists like you, Dr. Bukhari, and patient advocates like you, Claire, I think these are critical for us in terms of achieving our goal. But certainly, we always have the patient in mind.
Somebody would be diagnosed, they'd have the right treatment for their individual condition and lead full, active, productive, interactive lives.
All right, well, thank you. Well, I want to thank both of you again for joining us today. I hope you enjoyed this session as much as I have, talking about remission in RA patients. I think it's very important that we continue the dialogue to be able to really elevate the needs of these patients and be able to address them appropriately.
Okay,
Thank you.
So if you'd like to hear more about what AbbVie is doing in rheumatology, I encourage you to visit us on Twitter @AbbVie or on our website at abbvie.com. Thank you.